very little research to date has investigated the experiences of clinicians in delivering family talk within community mental health settings. We conducted in-depth interviews and focus groups with 41 clinicians and managers who had been involved in the PRIMERA programme of research. More than 80% of practitioners were employed with the adult and child mental health services, including mainly social workers, but also social care workers, clinical nurse specialists and psychologists. Similar to our family participants, service providers reported benefits for approximately 2/3 of families across different diagnoses and mental health settings, including reduced worry and stigma, a greater understanding of the impact of parental mental illness on family members, and improved family communication. Perhaps not unexpectedly, sites varied in their capacity to successfully embed family talk with key enabling factors such as, firstly, adequate managerial and organisational support and resources, secondly, clinician skill and interest in family-focused practice, and thirdly, establishing interagency collaboration across adult and child mental health settings. Implementation challenges included, firstly, recruitment difficulties due to parental stigma, concerns about discussing the topic with their children, and relapse in parental mental health and family crises. Secondly, there was a resistance to family-focused practice from some clinicians and managers due to resource constraints and because it was different to their usual more individualised and crisis-oriented way of working. Thirdly, there was extended disruption in delivery due to COVID-19. Our clinician-focused findings show that family talk can help families across different mental health settings and diagnoses. The results also illustrate several resource-related and ideological barriers that could undermine the longer-term sustainability of family-focused practice, particularly in the absence of appropriate policy guidance. A multi-level public health response is required to address these, including in particular Think Family policy and practice standards and dedicated funding for family-focused practice. These standards might include the following. Firstly, auditing of the parenting status of adult mental health service users. Secondly, balancing the priority given to patient confidentiality with unmet family needs. Thirdly, equipping clinicians with the time and resources to undertake family-focused practice. And lastly, increasing the collaboration between traditionally segregated adult and child mental health services.